This one's for Dr. Andriole. Please describe the issue with an issue with the European trial. This was just submitted a little bit. So, in other words, you've seen the data from the European trial in comparison with your PLCO data. You want to?
I mean, no trial is perfect. Let's be honest. Now, the original ER-SPC and the update. There's only 2 of the 5 major countries that showed a mortality benefit, and there are people who argue that the trial wasn't analyzed appropriately, but I don't know that. I don't have any expertise to say that. Another concern is that the largest component of the ER-SPC, which is the Finnish component, which, by the way, was larger than PLCO, and had about 2 times as many prostate cancer deaths in the control arm as the control arm of PLCO, that the Finnish component, which apparently was free of all the contamination and all the other issues we hear about all the time in PLCO, notwithstanding that, it is also a negative trial of over 80,000 men followed for about 13 years. So that's got to cause some concern. And finally, and this has been batted around for the last several years, there are treatment differences, because in many of the countries, in Rotterdam, the Rotterdam component, I think, is a pretty good example. If you were randomized to screening, you were called in to the medical center, and so all of your decisions about biopsy, about treatment, were made at a center of excellence, whereas the people in the control arm were seen out in the community. And as we've learned over the years, a radical prostatectomy done by an expert might be better than a low-volume surgeon doing a radical prostatectomy. It's likely that the form of radiation therapy and the type of radiation therapy was better at the major center than it was in the community. And furthermore, there were overt treatment differences. So you were much more likely, even with high-risk localized disease, if you were in the control arm of the Rotterdam component, to receive just hormonal therapy than you were if you were in the screened arm and you were diagnosed with high-risk localized disease. So these have all been batted around over and over and over again. I don't think we should stand here, pointing the finger at each other. I think, the conclusion is that PSA-based screening works. Now, we didn't do it right in PLCO, and I'm not sure it's done perfectly in every component of the ER-SPC either. And if we are going to make PSA great again, we've got to do it better. So, I don't want to be confrontational at all.
Well, that's one between you.
Yeah.
No, you don't need to, but there are some drawbacks when it comes to the Finnish study. We have the same incidence and mortality rates as Sweden, but in Göteborg, please remember, they had a limited number of skilled surgeons perform a radical prostatectomy. And also, please remember that they were screened every 2 years. That was one of the differences between Finland and Sweden. But then look at Southern Europe and Spain and so forth. They started later on in France too, and they shipped out the patients to GPs, et cetera, et cetera. So there are differences between the centers. That's the reason I highlight that to screen them every 2 years, have a limited number of doctors involved, and they also control the non-screen group in Göteborg. So, it stress the importance when you really want to initiate screening, you have to do it properly.
Yeah,
and that's a take-home message.
Yeah.
So, in keeping with that vein, can you explain or maybe re-explain what you mean by organized versus opportunistic screening?
Now, opportunistic screening you have already going on in this country. We have it in Europe too, especially in Western Europe and Scandinavia. It means that by chance you have a PSA test by a GP or family doctor, et cetera, like David alluded to earlier this morning. Organized screening, it means that they are actually sent to a specialized center for prostate cancer, like in Göteborg. Every 2 years it's taken and evaluated and so forth. So this is what we mean with organized screening.
Yeah, by the way, there's one further criticism of PLCO that hasn't been mentioned over 1,000 times in the last year, and that is, PLCO in the screened arm was only screening annually for 7 years. It was not ongoing, indefinite screening. So that's another sort of weakness in the design of PLCO, in addition to all the contamination that we keep hearing about. On the biopsy rate, I will say that 30 to 40% is within 1 year of an abnormal screen. If you said, give me a 4-year interval, 85% of the patients had had a biopsy, either prior to entering the study or on the study. Only 15% did not get a biopsy. If you said you have 4 years to react to a abnormal PSA, and the reason we chose that was many of the ERSPC sites were screening every 4 years. So you
Correct.
Okay.
Correct.
Dr. Partin, you had a comment?
Just one quick question along
We
these
need a
lines.
microphone, too.
Along
Roving
these
mic.
lines for Anders, you showed that data at the end of your talk, and I too was astonished at that. That's amazing,
Yeah.
wonderful data. But at the beginning of your talk, you said that you did not have recommendations or guidelines for screening with PSA for prostate cancer, and still don't. Do you think you will now?
No, we don't have any recommendation in any European countries whatsoever so far, but I mean, we're getting closer and closer based on this data, for sure, especially in Western Europe and Scandinavia. So based on the latest data now published only a month ago, I mean, how to refuse patients to undergo PSA testing, I cannot understand that. So we have a debate with our government, and that's ongoing now in European Union.
So what's your, Anders, what's your argument or position against the 1.5 cutoff?
No, I don't think I have a strong argument against it, but I mean, you find cancers between 1.5 and 2, but at that time, even Fritz Schroeder was reluctant to use a lower threshold rather than 3 or 4. Like you used in the United States, you had a threshold of 4. But we know for sure there are a lot of high-risk prostate cancer with a very low PSA level. So I think we are moving towards a lower level. On the other hand, we're going to detect, like we did in the Göteborg arm of a European randomized trial, 30%, more than 30%, 1/3 of them had Gleason 6, low-risk prostate cancer patients. But if you follow them over time, things happen in some of these patients.
We have a lot of good posters at this meeting. I want to remind people of that. But one of the posters that we have, I'll just let you know what the results are right now, is that we used the SelectMDx urine test in men who underwent screening at our institution as part of Prostate Cancer Awareness Week. And with over 200 some men where we did the urine test, and we wanted to do another test, a blood test, but that company didn't provide us with it. And what we found out, there was not one person who had a PSA of less than 1.5 that had anything but a very low risk SelectMDx test. So, you know, every once in a while you're going to find low-grade cancers, and we all know that, we all see it. But at least in that population, I'm sure with more you're going to find it, but it was very encouraging.
Scott?
Scott,
could I ask a question?
Yeah, where are you?
Here. So in the European studies, there are different genetic populations, and it struck me particularly in Finland, since I know something about it. There are Swedish-speaking Finns and Finnish-speaking Finns, et cetera. So the question, and the U.S. has such a polyglot of patients. So the question really is: are there genomic predispositions that can affect who is screened and how, that have fallen out of either the PLCO or the European studies?
We haven't done any proper genetic testing of our population. It's ongoing actually in Sweden, but also especially in Iceland, because you know we have Icelandic population, 320,000 people. They went over there 1,200 years ago from Norway, so they've been isolated for 800 years. It's a wonderful cohort of patients to really look at when it comes to genetics. And but of course there is a great variation in Europe too. I mean, the Vikings, we raped and killed everybody in Europe 1,000 years ago. So there are a lot of Scandinavian genes you'll find in Scotland, even in France, and all the way down to the Mediterranean Ocean. So we have a mixed population too, but it's not like a melting pot as we see in the United States, of course not.
We have a number of questions that are looking at life expectancy, age, associated factors with this. So why don't we refer these to the panel? shouldn't all reports of screening mention the mean life expectancy of a group? That's one. And two, when you talk about mean time to death, some of the VA data shows that it's 17 and a half years with prostate cancer. So when we talk about these 10-year results, are we being premature? Would anyone like to address those two issues?
Yeah, I mean, I think you're right. I mean, 10 years is a relatively early snapshot of what's going to happen to men with prostate cancer, for sure. I don't know how long it should be. Maybe it should be 20 years.
Yeah.
Maybe people are a little less mobile in Sweden. I don't know. In the United States, people seem to move around, getting different jobs in different parts of the country, and this organized screening is maybe not as plausible in that type of migratory population because, the patients don't often feel responsible for remembering to order a PSA. They expect the doctor to order the PSA, and they hop from doctor to doctor. So we could have that kind of sort of cultural challenge against effective use of PSA.
So, Dr. Crawford, when you mentioned the 1.5 PSA cutoff for making discussions, informed decision here, should that be the same across all age groups? So, if you've got a 1.5 in a 49-year-old, is that the same as a 1.5 in a 65-year-old?
What I learned from that was probably the hardest paper I've ever published in my life, and I learned that if every objection's overcome, nothing's ever accomplished. And the issues, the feedback we've got from everybody was good, but you can't please everybody, and you have to have some guidelines, and that are sort of okay. We said in there, and men with 10-year life expectancies, and then people say, well, there should be a cutoff, there should be velocity in there should be everything else. Well, the whole thing, this is supposed to be simple, and it's not perfect, but it is a way forward, and I think it works. So we need to, we need to tailor. It's the art of medicine. I mean, it doesn't fit everybody, but I think that it's a way forward with family practice, and that's where we got to start. We've gone out and presented this to family practice doctors, and done this. And Matt Rosenberg, who'll be here tomorrow, has actually went to their annual meeting and did surveys, and most of them in their heart of hearts believe there is a benefit to early detection of prostate cancer. They just don't like all the muck that's around it.
Last on screening, and then we'll turn to some of the biomarker questions. Jerry, you have any data on incidence of impotence or incontinence in your screened population?
No, we don't. The treatments were, the biopsy decision was made in the community. In PLCO, the results were reported back to the patient and his doctor. And that's why there's heterogeneous decision-making. Whereas, it may have been more uniform in an organized screening setting. So we don't know anything about that. I guess maybe the PIVOT trial has pretty good information on impotence and incontinence in the radical prostatectomy-treated patients. And maybe Matt could tell us about the impotence and incontinence and other issues in radiation treatment.
It's 100%.
100%, yeah.
Yeah, both.
Let's turn our attention to some of the biomarker questions
So
here.
wait, let me just add something. Jerry, you were in MTOPS with me too, right?
Mm-hmm.
And then we had PLCO.
Right.
But if I remember correctly, a great majority of men that were on both of those trials when they entered had erectile dysfunction, because there were some questions asked about that. And a number of them actually had, without even treatment, had incontinence, and that's BPH.
Mm-hmm.
Okay, so are any of the tests that we've talked about today, such as 4K, Select MDX, useful to follow men on active surveillance and omit the periodic biopsies that are part of those regimens?
We've looked at several of them so far. The initial study on PCA3 showed that because all the men on active surveillance have prostate cancer, it pretty much tells you have prostate cancer, or they didn't change much over time, and we don't recommend using PCA3. 5, we've still are analyzing that to see if it does change with time and is a predictor of progression. In order to eliminate prostate biopsies in our cohorts, I see, looks like Lori left, but We have been using multiparametric MRI. So if they've undergone a series of biopsies, nothing has changed. We use the MRI every 2 years to follow them. And that's usually in the more elderly gentlemen.
Anyone else want to comment?
We're collecting data from our active surveillance and then also from our mapping biopsies and targeted focal therapy groups. So we've got sort of a hodgepodge of men that come back for yearly biopsies pretty much. And so we do that for a few years, and if they're negative, we stretch it out. But we've been, in the last year, ordering the Select MDX urine test on people and PHI. And we have PCA3 too, Alan. It didn't work for us. But so far what I'm seeing, and these numbers are very small, is that the test is not missing pattern 4, 3, 7, and above. So if you're willing to accept that, I think we're going to be able to say that this test might buy you some time for not doing follow-up biopsies or not doing them as often. But we'll see. We need more data.
I don't know if, because we haven't really used it, the 4K score may have some, because of its potential strength in finding high-grade disease, may have a great possibility in that cohort. I don't know, has anyone seen a study on that? I can't wait to use Select MDX in these patients. Your data looks intriguing.
Yeah, we're trying to use MRI to avoid repeated biopsies, and hopefully, one of the PET agent, some of the PET agents, whether it's PSMA based or otherwise, may also be useful.
But an MRI is more expensive than a blood or urine test, I think,
Yeah.
and you're still going to miss them. I think that's going to be the future, is to be able to determine who's at risk. Mm-hmm. And we're doing it right now, and unfortunately I don't want to say anything negative about the 4K company, but we're not able to get that company to be convinced that it's a worthwhile endeavor right now, but we're trying.
In Europe, I can say we dropped PCA3. We couldn't repeat the initial data, and we are more using now MRI. I think too much, actually. That's the reason I was eager to listen to all the talks this morning, being very promising.
So there's a question here that, are there prospective studies that show that a decision via Prolaris or Oncotype or any of these tests is a good decision? I think the question is referring to is clinical utility studies. And I know, Dr. Partin, you mentioned a couple in yours. Anyone want to talk about clinical utility? Are these changing practices?
Yeah, are they changing it in the right direction?
In the right direction?
We don't know. I don't think anybody knows that.
I mean,
in my view.
I think we're certainly changing habits.
Right.
If you look at the Confirm MDX clinical utility study, it showed that you dropped repeat biopsies by about tenfold if you use this marker. But the question is it a really good decision in the long run? And I think
Don't know.
some of the data is
We don't know.
premature. Yeah.
I wanted to talk about that. Matt Roach from UCSF. It's interesting how different people can see the same data and reach totally different conclusions. I look at those data, the Polaris, the data that predict, are these people going to fail? Do these people need post-op radiation or whatever to give me ideas about whether I want to add hormone therapy to the radiation, not whether I want to use radiation or not, because anybody who has a metastasis within 5 years has really bad disease. I mean, using time to metastatic disease as an endpoint to decide who to radiate really doesn't make any sense, because if you have a metastasis at 1 year or 2 years or 3 years after you were treated, that appears on a bone scan, you probably already had the metastasis.
Yeah, it was out of the bag.
And those are the patients who are going to benefit from early hormone therapy combined with radiation. So I don't think there's a test yet that tells you radiate or not radiate. I think that if they have early metastases, those patients need to get hormone therapy combined with their radiation.
Any comments from the panel? How about Decipher? Anyone have any data regarding Decipher as a marker for radiation outcome?
Yeah, actually, there's a lot of good data.
Yeah, I mean, the validation studies correlated, You know, if you're at a low risk decipher test, the genomic classifier result, it didn't matter whether you received adjuvant or salvage radiation, and your overall failure rate, metastatic rate, was very low. On the other hand, if you had a high score and you had received salvage radiation, you did very poorly, whereas the men who received adjuvant radiation did rather well.
You want to comment on that?
That was exactly my point. So with that same data, you know, using metastasis as the endpoint is not appropriate for somebody who just had a radical prostatectomy, because you already knew that their risk of having metastases was low, and then you're going to say, okay, well, did you get a metastasis within 5 years? Okay, well, you didn't need radiation. That's not the question. The question is, all of our studies that look at the survival impact of treatment show benefits of treatment at 10 and 15 years after the treatment. Mm-hmm. So seeing an early metastasis endpoint is not safe to tell somebody, you know, based on these data, because we didn't see metastases at 3 years, therefore you're unlikely to benefit from radiation.
But they have some data. They have some data on high decipher scores. That goes along with what you just said, that where patients got radiation and didn't, and the radiation didn't matter.
Well, but they needed
And that's basically what you said. And they need hormones, and that's what I do. But then the argument when we present those patients that our second opinion, is that, well, you should radiate them too, in addition to the hormones. And you know, we all know, I think this is all going to change, that these patients have micrometastatic disease. We just not picking it up. And with some of these newer scans, I think we'll find them.
So let's go opposite direction in the active surveillance line. I don't know if this is a question or more of a statement. Is the bottom line is that 20-30% of low and very low risk actually are higher risk when you look at outcomes. So don't all men who are considering active surveillance, shouldn't they all have an Oncotype or Prolaris or both? Your view on that?
Well, I think what the person is trying to say, and you just erased the questions, and I don't know what it said, but
sorry.
But anyway, it is that, you know, why do you do these tests? Because in patients that we deem very low risk, NCCN, AUA, whatever you want to use, EAU. Actually, I think EAU has great guidelines, by the way. And they is that the bottom line is 20 to 30% of them are harboring some badness, and that's what gets you into trouble. And so we try to find that with MRIs. We follow patients, and 20 to 30% will fail, and all these active surveillance things. We do biopsies, do all this stuff. We do mapping biopsies and find it. But aren't these tests supposed to find that 10 to 20%? Is that what the person's saying? And then why aren't we doing those instead of all the other stuff we're doing, I presume?
We've been
do we believe in it, and what's the penetrance?
We've been selectively ordering them, but not across the board. We've had 20 years to look at the Epstein criteria and tweak it and change it and go back and analyze it again and again and again to prove that it really does predict pretty well, and then we still miss people. These newer tests don't have that 20-year data yet. Right. You know, we don't exactly know to take a man with one core Gleason 6, less than 5%, and his one of his genetic score tests, you know, comes back in the intermediate range, that we should, you know, jump to that. But taking a man who doesn't want to get treated, he has 4 cores positive, 50% of Gleason 6 in one core. I think it makes sense to give him comfort that his decision not to get treated is maybe okay, or to show him you probably do have some aggressive component. But I don't think across the board they should be ordered.
Can you discuss the cost and insurance coverage for some of these markers? Is that an issue?
Somebody had a slide on cost.
Well, we had it in our paper, and then Alan had one, and all that. You know, when you go to who to biopsy, you've got. There's only 2 tests that really have the across-the-board approval, and that's PHI and PCA3. Okay, the other ones have, Medicare pending coverage and local coverage determination and things like that. Some of them do, some of them don't. I don't want to get into the dirt of what's been said about some of the tests by Medicare, but at any rate, most of the companies in general, and they're out there, they don't go after people, and throw them in jail for not paying. That they'll bill them and try to. I think they have to through Medicare, and then they will take a minimum of $100 or something else like that and walk away. At least that's what I've seen. I don't know what other people.
I've had the same experience. If we're willing to write a letter and the patient's willing to talk to the company, that they're not getting $2,000 bills from the companies for these tests, and it's been in the range of 150 to 200. It's tough for us because you'd really like just to go on your Epic and click a box and everything gets taken care of, like your PSA test. And Phi is like that for us now, so we've not had any real problems with that.
There's a question here about tissue testing. It asks, which tissue is tested? Is it appropriate to just look at high-grade tumor when we know that some 3-3 is also destined to be lethal? I'm not sure what this is referring to. Maybe the Decipher that looks at the highest parameter. The other tests really do apply to 3-3 cancer.
On the Confirm DX, they're not looking at cancer
at all, right?
Because the Confirm DX originally wasn't determined to tell us if you have high-grade cancer. It was determined whether or not that high-grade pin may predict that in the same area there may be some cancer, not specifically 3-3 or 3-4. We don't send our cancer biopsies positive, to get the Confirm DX. They tell us that, you already know they have cancer. This test isn't designed for that.
We had a question about Confirm and whether or not it uses all the cores. You should. All of the negative cores should be analyzed. In fact, the data we showed, I believe, had to have a minimum of 6 cores analyzed to be a part of that. Anything that fell below that fell out of there. So anyone else have am I wrong on that? I think it's all negative cores need to be analyzed for the Confirm. So in terms of using these, it seems we have a number of options, particularly for understanding who to treat. We have Prolaris, we have Oncotype DX, we have Decipher. Should they all be ordered? Is this just preference on which one that we should be dealing with? Where do we go?
I don't think anybody knows it. Could you put up the last slide of my whom to treat slide? This is Eric Klein, who's been involved in the development of most of these tests. This is his view, and I thought maybe we should comment on
Yeah,
that.
I think that was a great slide to.
So while you're doing that, I just want to remind, we got a message from the ARS table back in the back that they only have Mac Roche's slides, and everybody else from the 10 to 12, for some reason, Paul doesn't have the slides. So if you're one of those people, make sure you get it.
Coming up in the next session, they need your slides. Great. So here it is in front of us. You want to talk us through this?
Well, let's just start with a patient with very low risk disease. I tend to agree. You probably don't need a genomic test.
Well, here's the problem with that, and somebody showed it and said it, is that in that very low risk category, and I don't think it was with Oncotype, but it's with you see it with all of them. There were high risk patients with the test, with their test, and you go, oh wow, why? There's not a lot of them, but there's a few of them, and so I mean. We all know that biopsy gets less than 1% of the glands, so you miss Gleason 8s. How many times do you have to see those to realize that that's an issue? So very low isn't, 100%. It's the bank robber. It's not 90%. It's, that's the problem.
But by and large, the amount of high pattern 4 or 5 disease in such a patient would be relatively small, and that to me is why I wouldn't do it. Except in a very, very young guy.
Wrong-o. For two reasons.
There you go.
One is
I should have known.
High-grade cancers don't produce as much PSA. Okay?
I tend to be somewhere in between because 1/3 of our screen population, they had low-risk prostate cancer Gleason-free, but after 20 years of follow-up, some of them were upgraded. I don't have the figures and numbers here, but I tend to agree with David, actually.
Well,
We
wait.
need an additional
But
test.
do we know when that?
All we're saying here is
occurred?
not to get a genomic test at diagnosis. We're not saying to quit following them, have them go stick their head in the sand. You know, the data, if you fit all the criteria for very low risk, we're just saying you probably don't need a genomic test at that time. You know, you come back next year, your PSA's gone up, your PHI's higher, the MRI's a little shady, it's PIRADS 3, maybe then
Yeah.
you do it then.
And then you spend a lot more money than just getting the test to
Just
begin
take
with.
their prostate
Well, which
out.
one would you do if you want to do it, David? So is the third column is what's the best endpoint? Is it the pathological endpoint, the mortality, or the metastasis endpoint?
Well, okay, so there's criticisms of both. Prolaris went to Belgium and the UK and got these active surveillance people that they didn't believe in treating, and that's where they developed the assay, the cell cycle progression genes, and death was an endpoint. And so Oncotype decided at Genomic Health that what was more meaningful was what would you have after radical prostatectomy? And then they start fighting, and so now what they're trying to do is Genomic Health has done the survival stuff, and Prolaris has done the pathology stuff, and they did it, and so they both have it right now. They're different tests, and I get asked when I give these talks for like one or the other or both is which one's better. Well, they both have different endpoints and different outcomes. And I have a lot of patients, and there's a poster we have at this meeting where they've gotten both. And that actually, I don't want to give it away, but basically it shows that there's reinforcement.
About the next category, low risk, intermediate risk, that group right in there. Is there any opposition to the recommendations of proceeding with a genomic test in that category? How about from our audience?
What's the
Yeah, let's have the audience vote on this
Yeah.
or comment on that. Because this is just opinion, by the way.
Right. So-
This is worse than the NCCN.
So do we have any stronger opinions from our audience here?
Eminence-based
Are you-
medicine.
I saw you nod,
Well,
so can you address it?
Well, we participate in trials too, but the bottom line is yes, that these low risk, high volumes and intermediate risk, the 3+4s, yes, it's very helpful. The problem is beyond that. We get the test back and it's a risk 3.2 polar or something like that. And then what do you do then? Are you going to rebiopsy him? We end up doing a bunch of MRIs. The patient's in a mindset for active surveillance is trying to, as much as possible, stick with it. He's not looking for prostatectomy, right? And that's so it helps if it fits what they expect to hear, it's wonderful. But if it's a bit borderline, then the story
Very
gets
good
tricky,
point.
and then we end up with a bunch of MPMRIs and mapping biopsies, and just like the panel knows.
Let's ask Brower to put on his non-myriad hat, and he knows as much about markers as anybody in this room, and see what you can say in a non-biased way.
Okay, so I'll be happy. I'll be very unbiased and in support of the organizer of this meeting. I'll salute our current president. Clearly, healthcare economics is at the forefront, and I would disagree with Dr. Klein's use of, saying that these markers aren't important in intermediate risk. If you really want to maximize the bang for the buck, it's actually in the intermediate risk where you get the best utility of prognostic markers. And with Prolaris, I'll just, because I know the data, it turns out if you're intermediate risk, about 1/3 of the patients will actually fall below our validated threshold for chance of dying of prostate cancer with initiated conservative management. About 1/3 will behave just like a typical intermediate. and would be amenable, I at least think, for single modality curative intent therapy. And a third will actually have the risk of mortality similar to high-risk patients, and therefore, where we really need to make the effort, I think, in affecting the 250,000 men or the 30,000 men that will die this year, is put those patients that look intermediate on clinical pathologic parameters to actually go to multimodality therapy.
But my understanding is that Polaris doesn't have the intermediate risk Medicare blessing, and Oncotype does, right?
No,
vice versa?
the opposite. We've gotten we're in negotiations, but MolDX has provided local coverage determination, which is sort of the initial step for favorable intermediate to be covered by Medicare. We'll know the details of that in the next few months.
So, but
And that would be in keeping with the new
So-
NCCN guidelines for favorable intermediate.
Jerry wants to say
candidates.
something.
well, maybe it's coming up in the next session on active surveillance. But Lori, what are you doing with patients with pattern 4 now?
Low volume.
Yeah,
You mean 3+4?
yeah,
Mainly treating them.
yeah. That's what I took from one of your publications, and so that's why I think maybe the test. I mean,
Yeah.
But that doesn't mean there isn't a subset who don't need treatment. I just,
People at the VA in wheelchairs on oxygen, right? And why did they get screened
but
to
listen,
begin with?
in Pivot, very significant proportion of the Gleason 6 would now be called 7, and they did not benefit from treatment at all. And
they had a very low, at least 10 or 13-year death rate.
So I mean, there's clearly
Gotta wait
Gleason
longer.
7. I agree with Mike on this. There's clearly Gleason 7 cases that don't need to be treated. We in a way, we err by saying any 7 or higher is clinically significant. That's only because we don't have a more accurate way to characterize their.
If you have a
future
little
clinical-
itsy bit, I think they're Gleason. We're seeing little bitty Gleason 8s on our mapping biopsies, like dots. What do we do with those?
Wait.
We're-
Before you leave the
That's
7,
small
before you
volume.
leave the
That's
Move,
7,
small
move
volume,
them next to a big piece
do
of
not
3.
use the data from Pivot to decide that you shouldn't be treating Gleason 7s.
Not all Gleason 7.
No, but that's an underpowered study. Okay, you got a 700 patient study of which only a small percent, you got competing causes of death in a VA population that has a higher mortality from other things. You can't use that Pivot data. If anything, the Pivot data support treatment.
But
It's an underpowered study. They promised a 2,000 patient study. They only put 700 patients there, and they were so
Only?
convinced that they were going to show the treatment wasn't beneficial that if you read the abstract, you think, gee, no evidence of treatment benefit, but you look at the patients who had adverse features, it suggested a benefit of treatment.
We're good.
Hey, Mike, how does it feel when everybody criticizes your trial to your face?
but
So yeah. So one other thing. Okay, go ahead.
no, I mean, the reason we have become less enthusiastic about surveillance for Gleason 7, we had about 250 patients with Gleason 7 on surveillance, and the 15-year mortality rate was 20%, even in the best group. So we thought, okay, that's too high, it's not a good strategy. But 80% of Gleason 7s at 15 years did not progress to metastatic disease. So, I mean, we need to do a better job, but we say it's significant because their chance is not 0. But
You're
it's-
saying that 20% of the patients in your active surveillance group died that had Gleason 7?
I'm going to show that data. in
Okay,
my talk
because
at
everybody
10 o'clock.
else saying nobody ever dies in active surveillance, according to Klotz.
I'm glad to hear that they're saying
So
that.
this
but it's
reminds
not
me of
true.
this reminds me of radiation therapy. Malcolm Bagshaw years ago said nobody died when they got radiated, and then they got lower doses and they got higher doses, and because the lower doses failed. But when they were talking about the lower doses, they never failed. I don't get
We
it.
have always reported
That's
our
why
prostate cancer mortality.
we need to straighten this out. No, the other thing is is that this month's Journal of Urology had a very nice article by Klein and that whole group looking at Gleason 6s, and 20% of those 6s were not good. And so that, that was the argument, because wasn't there was a meeting, and, well, Scott, you know this about Gleason 6s or toothless lions. They shouldn't be called cancers, but they're back and forth. And I think this paper shows that 20% of them were bad. They used the genomic grid thing and a couple other things to look at them. So to me, that's a reason Klein should be looking at these tests and those Gleason 6s, and found out that 20% are bad. So maybe he was wrong right there.
What do you mean by bad? Well, you shouldn't just say bad. You need to. I mean, 20% may have some adverse genomic
They
features.
behave like they behave like 7s or 8s or that. And when they had radical prostatectomies, they had worse disease.
They didn't metastasize them.
The metastasis rate was very low, not zero. It was very exorbitantly low for those. Interesting, the genomics of it was really interesting. It kind of reflects on what we heard this morning. Some of the genomics of 3-3 cancers really mimicked what we saw in higher grade cancers. In particular, was one case of a 3-3 that had a BRCA abnormality. So ignoring that one is probably a bad idea. So I think there is evidence to suggest that there is a subgroup of 3s that are destined to become worse, and I think that's the point. But, prostate cancer is also a multifocal disease, and the multifocality doesn't always occur at the same time. I think we lose track of the dynamics of prostate cancer, too. We look at these slices of life. When I have prostatectomy specimens, 80% of my prostatectomy specimens have more than one cancer. But that's one point in time. That does not mean that the 3-3 that you have today doesn't mean you're not going to get the low volume that you just mentioned, the low volume Gleason 4-4 that occurs sometime down the future. So the risk of having prostate cancer and dying of it is having a prostate.
Scott Egner, you were on the paper too, right?
Yeah, I just want to pose a little bit of a different view on it. I use some of the genomic markers, but I feel most men with Gleason 6 do not need a genomic marker. And just because there's 20% in the Klein study that show some genomic instability, that is not a real endpoint to a patient. And I would just pose the following for discussion. So there's really good data in huge cohorts of men. So when I was a fellow at Sloan Kettering with Dr. Easton, we combined with Dr. Partin, we put together a cohort of 24,000 men, of which most had Gleason 6, and they were surgically removed, but not a single one had a metastasis or died of their prostate cancer, saying that Gleason 6 that was there for a while was incapable of metastasizing by the time it was treated. Jonathan Epstein has looked at a cohort of 14,000 men that had lymph node dissections during prostatectomy, couldn't find a single case with a contemporary Gleason 6 that had gone to the lymph nodes. We just published a paper in the European Urology of 7,000 men that had prostatectomies, of which 2,500 had Gleason 6, and the rate of extracapsular extension, just Gleason 6 even getting outside the capsule, was 0.28%.
So why did they have radicals, all those men?
Well, most don't, and that was a former era, and hopefully nowadays they don't.
And how do you make that decision? Through markers. Thank you.
Okay. I respectfully disagree, but...
Can I
They
just
all did well, but
throw up
the reason we didn't
my little discussion point? I've got one slide to kind of finish this up. We got 5 minutes left. If it's coming up. And it's basically to ask, what are the obstacles when we're looking at utility of using biomarkers? What are the obstacles before us? And I've listed a few things that we can just question. Do you have that? Should say panel questions. Where's Paul? But I'm asking the obstacles. What are the major obstacles for why these tests aren't being widely used even now? Is it education? Have we not gotten the word out very well? Is it confusion about when to use a test and who to use a test on and what test to do? Is it cost? Is it reimbursement? What are the biggest obstacles that we have in front of us so that we can address these some way down the line?
All of the above. If we had to rank them, I think a number one, we're or I'm seeing, is communication and confusion as to the actual use and utility of the tests. Everyone hears in the New York Times new DNA test for prostate cancer will tell us all. And they walk in and say, I want that DNA test. They don't understand which one it was or, what it is. And it's our job to know which one and which time. I think with sampling error, we're not going to get any better with that. If we're relying on the tissue, we're sending the people to look at the genes to give us the answer, and we missed that little 8 that David's talking about, and it didn't get to them, then we may not know.
Yeah,
That's a great list.
I said a comment in a pathology meeting one time that really upset all my colleagues. I said, pathologists really don't make diagnoses on patients. And they were like, what? I said, no, we make diagnoses on tissue. And if you're not given the right tissue, you're not going to make the right diagnosis. That's why a negative biopsy does not necessarily mean that the patient doesn't have cancer. And so I think the same thing applies here. It totally dependent on what you get. So if you get the right material, it's very useful. Yep.
Good discussion.
We have issues about 10% of patients where, for technical reasons, they sometimes cannot run the molecular pathology testing. That's frustrating to patients, the pathologists, sometimes finger pointing, and that's an issue which pushes costs up. And rather than have the patient get 3 biopsies, and we end up doing MRI because you want to do an invasive test with risks. So there's additional uncertainty. Some pathologists get frustrated with that because they have a couple of those, that would be in a month, that the tissue is no good, and say, well, what are we going to do now? What is it for, sir? So the industry is actually helpful. They don't charge those patients, at least from what I understand. But the fact that it's a 10% roughly, based on hands-on after a couple of hundred patients done now with various companies, non-informative testing is a problem.
So how about the bottom one? Is there experience from people in the audience in ordering these tests that the pathologist got in the way? Either they said, I don't believe in this test, or we can't, we're not releasing our blocks to a company to do a test because we need to have them. Is that happening? I know it doesn't happen in the academic centers, but I think it happens more often outside of that. I have gotten comments about our pathologist doesn't believe it and won't let us run the test. Is that a problem? Does anyone say? We got a hand in the back. So they've actually seen that happen. So we try to, one of the points that Dr. Crawford said this early, that we're probably educating the wrong people if we're just educating urologists. We need to educate family practice and internists on how to use tests correctly. But we also probably need to educate pathologists. I know a lot of pathologists who don't know any of this stuff. I get questions all the time. What is what is confirmed? What is the Oncotype DX? Should we actually release this? Is this an appropriate use of a test? And so we need to get the education out to pathologists as well.